Welcome to the MCOL Podcast, a podcast from the great people and partners at MCOL. If you're in the business of healthcare, MCOL is in the business for you. At MCOL, we're proud that since 1995, we've been a leading publisher of healthcare business information, webinars, training software, resource books, directories, web content, and now podcasts to healthcare professionals. We help leaders unwrap healthcare business information through a variety of membership solutions. MCOL memberships serve health plans, hospitals, provider groups, physicians, pharmaceutical organizations, employers, government, research organizations, and many other companies. Check out all our great resources, including the MCOL podcast at mcol.com and many other podcast directories. Today's featured guest on the MCOL podcast is Erin Benson, Director, Market Planning for LexisNexis Health Care. Erin Benson is responsible for design and execution of strategic planning for member-patient identity and social determinants of health solutions. Please join me in welcoming to the MCOL podcast, Erin Benson. Erin Benson, via internet telephone, I want to welcome you to the MCOL podcast.
Thank you. It's great to be here.
Well, I'm really excited to talk to you today, but let's start with telling us a little bit about your background in healthcare and your role with LexisNexis Health Care.
Yeah, I'd be happy to. I'm the Director of Market Planning at LexisNexis Health Care, and I always like to start by just giving a little bit of background on the organization in case people haven't heard of us. So we're a trusted data analytics provider. We use over 6 petabytes of data on providers, claims, patients, and members to help different healthcare organizations to address business risks. And really, we're looking to help with challenges like fraud prevention, regulatory compliance, cost reduction, and improving patient outcomes. So today we serve 90% of U.S. commercial payers and over 3,000 different provider organizations. We also work in life sciences, pharmacy, and government healthcare organizations. So the organization I work for has a very long history, and then specific with my role as Director of Market Planning, I focus on driving our strategy for our identity management and our social determinants of health data and analytics products. So these products are all based on our public and proprietary records data. So this is the type of data that gives healthcare organizations insight into their members and patients, as well as any other users of their systems. Over the last 2 years at LexisNexis Health Care, I've focused on social determinants of health and how it can help improve health outcomes, and I know that's what we wanted to focus on during this podcast today. The truth is, even though I've only been doing social determinants of health specifically for the last 2 years, I've been interested in social determinants for a lot longer than that. I worked previously at a human capital consulting at Deloitte Consulting, and there I focused on understanding what factors influence and drive human behavior so that I could help employees in those organizations to adapt to major organizational changes. So I've been really interested in what motivates people towards certain behaviors, and I found in healthcare that means asking questions like, if we all know that what a doctor or a care manager tells us to do is going to make us healthier and feel better, why is it that we don't do it? And the answer we're discovering lies in the social determinants of health. So I like to share a story about a friend of mine who was a runner. She was training for marathons, so she was running miles and miles every day, and about a year ago she hurt her foot doing this. And the doctor, after examining her, put her foot in a boot and recommended that she go to physical therapy. Well, normal convention would say that would have solved the problem, except that my friend never went to physical therapy. Her foot didn't heal, and she ended up needing surgery. So the question is, if you know only this friend's medical condition, it doesn't make any sense why they wouldn't go to physical therapy. I mean, didn't they want to get better? But the answer is they did want to get better. It's just not the only thing that they wanted. So if you start looking at social determinants of health, you would have known that this person had just bought a house and it needed a new roof. And so they had to decide whether they were going to spend their finances purchasing the home and fixing the roof, or if they were going to spend it going to physical therapy. And they made a choice to try and split those finances and hope that the boot would work. And I think what's been fascinating about watching social determinants develop in healthcare is that my friend's story isn't unique. These are the types of choices that patients and members are making every single day. Their financial situations, their educational backgrounds, where they live, the people they surround them with. And these all impact how well they're able to take care of their health, and this in turn influences their health outcomes. So as a healthcare community, we're starting to realize this and just how important it is to address these social determinants, and really where my role is in helping drive that education and change around this growing understanding.
You mentioned this idea of social determinants, and in my research, I found that LexisNexis Health Care refers to social determinants of health as the X factor for improving member health outcomes. Can you explain what you mean by this?
Yeah, absolutely. So what we mean by this is that it's really possible to learn a lot from claims and medical data, but you can't learn everything about an individual. You don't get that comprehensive picture by only focusing on claims and medical data. So the environment in which a person lives impacts their likelihood to develop health conditions and their likelihood to effectively manage those conditions. So what we mean by the X factor is all the things that happen to that patient or member outside of a clinical care setting that influence their behaviors. So I shared a story earlier about my friend, and if you think about it, her X factor was her financial situation. With limited funds, she had important decisions to make about where to spend her limited resources, and she chose to try and minimize her healthcare spending so she could fix the roof on her house. That's not going to show up on a medical chart. But with social determinants of health insights and alerts, the care provider could have seen she was a new home buyer and asked questions to determine if she could afford physical therapy. So there might have been other options for her, like more home-based physical therapy exercises she could have done or more cost-efficient programs she could have attended had the care providers known about her situation. So it's really important that care recommendations be a good fit for a member's environment and not just their medical condition. If the recommendations won't work within the person's physical environment, they're not affordable, they're not conveniently located, or they're provided in a way that's hard for the member to understand, they're not going to be effective at improving health. And this has been cited by a lot of different organizations, including the CDC, the U.S. Department of Health and Human Services, and they recognize lots of areas of social determinants of health that can impact a person's overall health beyond just the medical condition. So we think it's really important to look at all of that information about an individual to be able to put together the best care recommendations.
What is the one top myth about sociodeterminants of health that our listeners should be aware of?
This is a really great question. On the webinar that we did with you all about a week ago, we asked this question, and we went through 5 different myths. So I'll quickly summarize those, but then there's one I want to focus on because it was the most surprising to the webinar participants. So the myths that we talk about a lot are, first, that social determinants of health is just more noise in an already data-overloaded world. The second one is that all data regarding a person's lifestyle, environment, situation, and behaviors relate to their social determinants of health. The third myth is that examining only individual socioeconomic attributes about a person will allow you to make accurate predictions about their overall health risk. Fourth is that aggregated data at the zip code or census level can be used to personalize care for a member. And then the fifth one is the socioeconomic data is only useful in combination with clinical data. And while I could debunk all of these myths, what I mentioned before was on the poll, what was most interesting to the webinar participants was this fifth one, that socioeconomic data is only useful in combination with clinical data. They were actually surprised to learn that this wasn't entirely true. So the first point I'll make about this myth is that we're not saying that adding socioeconomic data to clinical data is without value. Certainly, adding socioeconomic data to clinical data can help payers to personalize care and more accurately predict risk, and we absolutely encourage it to strengthen existing predictive models and gain more insights into hidden risks that aren't surfaced by clinical data alone. We've had organizations test this data, and they've found, for example, that adding socio data to clinical data can improve the predictive power of low-intensity ER model predictions. So it can certainly be useful adding it to clinical data. It's just that it's not the only way that it has value. In the absence of clinical data, using only socio data has proven to be useful. It can more accurately predict risk based on total cost than traditional age-gender predictions alone, and it is shown to be as and sometimes more accurate at predicting readmission likelihoods in certain clinical data models. So if you consider new members who are coming in with limited to no clinical data, this can be incredibly useful at predicting risk before claims begin to occur. The other way this is useful without clinical data is it goes back to our point on social determinants being the X factor, which means that socioeconomic data can reveal barriers that members may face to adequately taking care of their own health that just isn't going to show up on a medical chart.
Can you give our listeners an example of how payer organizations can utilize insights from SDOH to provide better care management for members and generate value?
Yeah, so the main ways that we recommend using this data is in predictive analytics and then also in care management. So referencing what I said before, the most common way we've seen payers and healthcare organizations using social determinants of health data so far has been to incorporate it into their existing claims-based predictive models to improve predictive accuracy, or they use it to create new predictive models. And this does work well. Our data scientists have found hundreds of correlations between socioeconomic health attributes and actual health outcomes. It covers things like total cost, hospitalizations, medication adherence, emergency visits, and more. So it's definitely valuable and viable use of the data to use it in predictive analytics. And this does seem to be the starting point for a lot of organizations because it fits most easily within their existing workflows. The second use case around care management, though, is where we're really excited about the potential for social determinants because this is where it can be really transformational. It has the potential to really change how we address care and personalize it down to the individual level. So what this involves is that social determinants of health data can be used to identify health barriers that, if you address these, can significantly improve health outcomes for patients by making the care recommendations fit with their life situation. So one of the examples I like to share is healthcare organizations have asked us a lot about if we have any insights into members who have housing stability issues. So the logic behind this is that if a member is constantly worried about where they're going to be living, they're not focusing on their health. And if they're undergoing treatment or they're recovering from a surgery, this becomes an even bigger problem because they may not have a reliable place to heal. So we can look at our public records data that gives us insights into social determinants of health, and we get a picture of their housing stability situation. So if we see somebody who's moved 6 times in the last year, we're seeing they're moving between apartments, 4 of those moves were results of evictions, we're going to start to have a pretty strong indicator that they may need support addressing housing stability. We could further see that their estimated income may have significantly decreased over the last 12 months, and this may indicate job loss or demotion. So knowing this could give us a place to start with having a conversation with the member and connecting them with the right resources and community programs. But on the other hand, if we see someone who's moved once in the last year and they moved from an apartment to a single-family dwelling, they've never had an eviction, and their estimated income has actually increased over the last year, then the care provider is probably going to deprioritize that kind of care management because that individual already has a stable environment. So having this type of information helps to prioritize who needs the care and then also to ask the right questions to figure out what kind of care they need. Some of the other barriers that we commonly look at are things like social isolation. This might require connection to support groups or more frequent follow-up calls to address their medical condition and make sure that they are getting support that they need. We see educational disparities. This may indicate the need for more education for those individuals to better explain the medications they're supposed to be taking or their follow-up treatments. Or even designing different education. We found that videos can be more effective with members in learning how to take care of their own health. Neighborhood safety is another barrier. If individuals don't feel safe exercising outside, that can have significant impacts on their health outcomes. So there are ways to help them to find more exercises they can do at home or to get them to facilities where they can exercise. So really by using the data to build models that predict the likelihood of different health outcomes occurring, payers can prioritize members for care based on their needs. But then by building models that identify these health barriers that are specific to social determinants of health, they can also inform care managers about the types of interventions that may be needed to improve those health outcomes. So if they do this, everyone wins because the healthcare organizations can see better financial outcomes and higher member satisfaction. And then the members win because, of course, their health is improving.
Erin Benson, Director of Market Planning for LexisNexis Health Care, thanks so much for joining us today on the MCOL Podcast.
Thank you. It's been great being here.
If listeners are interested in learning more about LexisNexis Health Care, please visit www.risk.lexisnexis.com.